Hello, my name is Marc Ryan, the Chief Strategy and Compliance Officer of MedHOK. The topic of today's podcast is the emerging healthcare landscape. Tens of millions of more Americans are now covered in private healthcare plans. The levels of insured is increasing, and it's really made possible by the following government programs. First, of course, we have the Patient Protection and Affordable Care Act, known as either PACA, the Affordable Care Act, or sometimes as Obamacare. This was the act that set up the healthcare exchanges at the state and at the federal level if a state didn't set up their own exchange. They have individual coverage as well as what's known as the SHOP program, which allows small businesses to enroll their employees through the exchange as well. Small business tax credits are helping the situation for small business as well. And of course, you have both an employer and an individual mandate that is slowly taking root in the new system, which will penalize individuals as well as businesses if they do not have or provide coverage. There's the possibility of merging PACA and Medicaid streams of revenue as well in states. So there are some programs there that in different ways are looking to sort of put those two things together to run a uniform system. On the Medicaid front, PACA was also instrumental in expanding Medicaid coverage in roughly about half the states out there. States were given the ability under PACA to get 100% federal funding to expand Medicaid to about 133% of poverty by family size. That's, again, taking root. Only about half of the states did so, but about half of the overall increase in enrollment has really come from Medicaid, about 7.5 to 8 million there, and then about 7.5 to 8 million people or so have enrolled in the exchanges to about 15 million people total. Also, in the case of Medicaid, it seems that the old antiquated fee-for-service systems in Medicaid are going away in favor of much greater penetration of Medicaid managed care organizations, which is also increasing the number of people in private health plans. There are dual eligible demonstration projects, too, that are health plans that directly contract with both the federal government and the state government to really merge the Medicare and the Medicaid streams of revenue. And lastly, of course, Medicare. Medicare Advantage has been growing tremendously over the past several years, despite the financial realignment and the deep cuts in Medicare Advantage rates that were actually put into play. Right now, about a third of all people covered by Medicare are actually in Medicare Advantage plans. 100% of the people with Part D coverage, as we know, are in private health plans. And lastly, in some markets, especially in South Florida and other areas, you can have well over 50% of all Medicare beneficiaries enrolled in Medicare Advantage plans. Although this is great news for health plans, at the same time, state and federal regulators are really enforcing a much more accountable infrastructure. They've been long frustrated by poor quality, for example, in the Medicaid program over a series of years, whether that's in the fee-for-service system or even with managed care organizations. As long as a decade ago in Medicare Advantage, there was strong concerns about quality there as well. And the federal government began to reform that. And you're really starting to see all lines of business converge on what I'm calling a national healthcare accountability model. Medicare Advantage is clearly leading the way for the past several years. Again, the enforcement regime and the quality infrastructure that the federal government is building in Medicare Advantage, led by CMS, is getting extremely robust. The Star program now is becoming very mature. The demonstration project has completed, and the number of plans reaching 4- and 5-star status is increasing dramatically because of the carrot and the stick approach taken by CMS to promoting quality in Medicare Advantage. And with Medicare Advantage leading the way, it's really sort of rolling out to Medicaid and other areas as well. Again, the state Medicaid programs are being told by CMS you have to put pay for performance into play, so you're starting to see quality bonus programs in those programs as well. New York and a few other states led the way, but now you're starting to see all Medicaid programs for managed care begin to offer quality bonuses and to withhold a certain part of the overall premium unless you achieve quality metrics. And it's only a matter of time before the exchanges, both state and federal, will begin to mirror Medicare Advantage. As that program matures and post-stabilization, you're going to see the same kind of STAR program and quality initiatives in the exchanges moving forward, probably only in the next couple of years. We're going to turn to a couple of trends now in healthcare. The first one we're talking about is really risk-adjusted premiums for healthcare. As many of you know, risk adjustment is a methodology of really recognizing the overall risk of an enrollee in your health plan. Essentially, ICD-9 diagnoses are captured on encounters and on claims, and that's run through a risk adjustment system to set an individual score, usually on each member, which then is rolled up to show an aggregate plan risk score. And essentially, plans are rewarded with additional revenue for having sicker individuals. Plans with profiles that are relatively well compared to other plans are getting less revenue. Again, this is very firmly embedded in Medicare Advantage. Part C and Part D has had this for a number of years now, and it tends to work very, very well, in fact. And slowly but surely, risk adjustment is rolling out to other government programs as well. In the case of Medicaid, as many as 30 states are using or will use a Medicaid risk adjustment. In the case of Medicare Advantage, that is HCC. In the case of Medicaid, the most popular is CDPS, and that's used by somewhere in the neighborhood of about 20 states right now in Medicaid. And so the same type of model applies here, again, in terms of risk adjustment, a slightly different Medicaid-specific model. The exchanges are now using a variation of HCC. Right now, we're on a retrospective basis for doing that, but moving forward, it will be prospective, just like in the Medicare Advantage program. So most importantly, what plans are really going to need to look at here is they're really going to need to get much more sophisticated on their encounter gathering processes to ensure accurate scoring to really survive in what's going to become a very tight revenue environment. And this really begins from the very beginning, working with your providers on provider education, on the need to submit encounters, all the way up through the actual submission process to the regulatory agency. And I think it's going to be more important as we go on to make sure that those risk adjustment tools that are out there interface with the clinical experience and really tie very much to the quality performance metrics as well. Trend 2 is quality performance. Again, Medicare is leading the way in this area, and the federal government is really using a carrot and a stick approach to improving quality. So Medicare Star, again, is taking root. We just heard some good news about Medicare Star recently, whereas just a few short years ago, only about 20% of plans had 4- and 5-star status because of the demonstration project. We're now at roughly 40% of plans achieving 4- and 5-star status. And now somewhere around 60% of enrollees are actually enrolled in 4- or 5-star plans. The Medicare Star program continues to morph over the year, but it's, again, doing very well. As this program evolves, it will be almost impossible to compete as a health plan without achieving a 4-star or greater score in the program. Again, CMS has dictated to states because of poor quality performance the need to really overhaul the Medicaid program and improve outcomes. Again, some states have been trailblazers like New York and have had their QAR program for many years, but all states now are moving down the road of a Medicaid Star program or quality bonus program. And dual demonstration projects, again, those projects where joint contracts are signed with health plans between the state and the federal government, are also having very important quality scores and bonuses in those programs as well. And they seem to have a 3-year period of rolling up strong quality performance as that 3-year contract evolves. PACA, again, if you read the PACA bill, it's only a matter of time before STAR will come into that program. Already we're seeing signs in terms of the need to have a quality improvement program and other HEDIS filings that clearly CMS is already moving down the road to fashioning a STAR program in the not-too-distant future. The third trend here is really greater clinical focus and sophistication. And this is one of those fast emerging areas, and it seems to be changing by the day. There are clearly increasing clinical requirements tied to top quality outcomes. And whereas before regulators were sort of a little bit hands-off in terms of exactly how a health plan conducted themselves from a clinical management standpoint, regulators are now wading into clinical protocols and policies to really ensure, one, that medical necessity requirements are being used, evidence-based practices are being used, and that they're being consistently applied to ensure no discrimination against a given member. There's also the new federal and state outside appeal systems that are really in all lines of business now, PACA being part of that, setting up the external review for non-grandfathered plans, which is really providing a much greater level of oversight into the clinical decision-making process. There's an increased focus as well on care management, where individuals with medically complex conditions are really being offered a greater amount of case and disease management because of demands by state and federal regulators. The state and federal regulators are looking for, number one, for plans to really identify and stratify these populations to ensure that there's member and provider engagement, and to really ensure that there are very rigorous individualized care plans, individualized care teams, medication reconciliation, and other things happening. And if you're not meeting these clinical protocol or these case and disease management requirements, again, there will be findings by state and federal regulators related to your health plan. The last area we want to talk about here is integration of technology. Technology is really giving rise to fairly cost-effective ways to engage members and providers and really monitor member behavior, status, and outcomes. We know that EMR acceptance and integration with health plans is increasing a great deal. There are the federal grant programs provided for in the Reinvestment Act, and there are slowly but surely mandates on usage occurring in managed care contracts, for example, encouraging plans to work with their providers to make sure that more and more individual providers and group providers have EMR access, and there's a level of meaningful use that's being used there. So this will clearly take time. I would expect that, to have full meaningful use and a deal of penetration with providers will probably take through a good 10 years or so. But nonetheless, we're now on a new trail where over time we're going to see health plans fully integrated with many providers and getting a whole bunch of secondary data that isn't always available to them now. And the second area is really more member-facing. You're starting to see those 18 to 50-year-olds commonly, if not exclusively, interacting with individuals through technology. So social media and technology-driven communication, especially in the younger generations, is strongly taking hold. But even those in their 40s and 50s now find that social media and technological communication is something they prefer and are very used to. So it's going to be very incumbent on plans moving forward to really create an environment where they can interact with their members using social media to some degree or technology to a greater degree, whether it's texting, whether it's email, whether it's other forms of technology communication. That will really be the best way for plans to move forward with these members in the future. We're also starting to see sort of remote biometric screening and monitoring beginning to take hold. While initially expensive, the cost of these kind of things is really dropping a great deal. A great example may be having a senior step on a scale to monitor for CHF, with the weight every day being automatically sent to care management systems so that changes in weight can actually be identified early so that individual gets to the doctor and does not end up into the hospital be a CHF may be worsening, for example. And this will also open up a whole bunch of new ways to ensure self-directed care and empowerment, which hopefully will also increase understanding of prevention and the need to really monitor chronic conditions by individual members as well. While we appreciate you joining our podcast today, I just wanted to close with MedHOK Single Platform for Care Quality and Compliance. Again, MedHOK offers this single platform in these areas. We offer products for care management, utilization in both the pharmacy and the medical world, as well as a care management platform for case and disease management, as well as risk stratification using the ACG tool. In the area of quality, we are a HEDIS certified HEDIS engine, and we can do year-round care gap management and remediation in addition to annual HEDIS filings. And in our compliance package, we emphasize appeals and grievance modules, as well as a complaints tracking module for the Medicare program. Completing this suite is our member and provider portal, which ensure that critical information gets to members and providers to increase quality and compliance for your health plan. Thank you again for joining our webcast.